So what we typically do is when we have identified one specific area we would like to find solutions for, we go out in the market, look for solutions that might already be on the shelves or just about to be released into the market. And we do some first pre-screening. We then select a number of potential providers. We send out a batch of cases from our own environments to test the algorithms in a first pre-qualification test, if you want, right? So typically we might have 50 or 100 cases being sent out, anonymized, of course. And then we run an initial beauty contest just to see what the solutions can and cannot do. And that is actually really interesting because there are sometimes interesting discrepancies between what providers think they can do and what we see they can do. So after that process, then we might have either one or a handful of potential vendors that we then engage in on more sophisticated testing. And what we did with iDoc was that we went through this process and we came to a point where we actually did a very robust, very large-scale test during 2019, where we tested around 9,000 cases from our own emergency radiology workflow. Basically, it's old cases that we run through the different iDoc algorithms to see the performance. And we came to the conclusion there that the performance was good enough for us to start to test using iDoc in real clinical practice, basically.
Quite important for the moment is that everybody is using it. And we feel that the accuracy for the pulmonary embolism and for the detection of the intracerebral hemorrhage is quite high. So whenever there's something flagged there, action is taken immediately if it's not taken already. But it's a good it's good to have something that you can trust that double checks what you are doing, or even tells you, listen, you have to look at this first, this case first. So I think the residents are actually quite happy to use the software. There's also, of course, the nice widget. That also has an impact on everybody because we are not always everybody involved with the emergency department. And now, due to the widget, we have this alarm. You can put it, you can set it off, but of course, I always have it on. And whenever there is a case flagged, I look at the case, and it's really interesting that you are now more connected to the emergency department than I was before. And so that's quite interesting. So impact, yes, I think. We didn't do a formal evaluation yet, but I have the impression that the impact for us is that we feel more at ease, and we are actually backed up by the software.
Yeah, well, back again to what was discussed also previously, right? You probably need to really understand what you would like to use the solution for. That helps before you start with large-scale implementations. I mean, we do around between 800 to 1,000 emergency CT cases per night. So we have quite a busy emergency radiology activity. And before you implement something in such a large scale, you really need to understand on a very careful level exactly how you want to use the solution, right? I mean, for example, do you want to present the results from the algorithms prior to the radiologist having had the first look, or at the same time, or afterwards, right? So these kind of things will have significant impact on well, both how well the radiologist will accept the implementation of new tools, and also how you can actually benefit from the results of the output, right? So it's quite good to really carefully think after you have done all your evaluation and stuff, also how to implement it, right? Where in the workflow would you like the solution to work? And for us, as you know, Elad, right, we spend quite some time together with iDoc also to understand exactly how in the workflow should the solution be implemented, and when to present the results and how to present the results. That was for us quite an important component, and also the processing time, for example, right? So that was for us a learning of really to try to understand before you enter implementation phase, to really carefully plan for for that part, right? Because it's difficult to make a lot of too many changes once you have started to implement something. So that was probably one of the findings. Another one is also how you communicate with the end users. In our case, with our referring clinicians, right? I mean, how would they benefit from what we are doing, and how do you explain to them what we are doing, right? So quite often when you talk about AI, many people have so there are some preconceptions, ideas, if you want, out in the medical community what AI is being used for, right? So in our case, we met a lot of I wouldn't say suspicious, but at least some ideas from our clients that, yeah, but you're implementing this, of course, to reduce radiologist time spent on images, which was not at least the case here. So that was another learning. And then, of course, you need to really assess, apart from the algorithm's performance, that you have an AI provider that you like working with, because there is a lot of need for adoption and you know, fine-tuning and things like that. So apart from having a fancy, relatively well-performing algorithm, you also need to find a provider that you really trust can support you through the implementation, further development. So that is another important component to really keep in mind if you consider to implement AI solutions, I think. And for us, and that might also be because we have a relatively large-scale operations, right? But for us, it was never really an option to start using iDoc, if you now take iDoc as a specific example, to use that via one of our other providers. Like, you know, you can go to one of these marketplaces and then to use a solution that is provided by your Philips, Sectras, Gs of this world, right? But for us, it was important to really have a direct relationship with the AI provider, because we needed to engage a lot with fine-tuning and to understand also where in the workflow should we integrate this specific solution.
Really a matter of trust in the beginning. The radiologists were hesitant about using AI, but I think the widget helped a lot. It's always on. It's on every PACS machine. So even when you're in the ultrasound room and there is a CT scan of the brain which is positive by ADOC, then it will show up. It will pop up. It's bright orange. You can't miss it. So everybody was constantly looking at the results of ADOC. Through the widget. That we have a user engagement of 100% every time. That's because of that. The other thing was that in the first time, at first the ADOC results weren't sent to the PACS. So when there was a positive finding, you couldn't find it in PACS, and that's what we needed, especially for the ER doctors, but also for ourselves, because when there's a negative finding, there's no finding. Then there still has to be an image in PACS so that everybody knows that ADOC looked at it. And when we managed to do that, it took a month or so, not that long, then you saw the trust really building up, especially when there were a couple of findings, mostly in the out-of-office hours, when the radiologist was tired and not looking very well, and ADOC found a small hemorrhage. Correct, that's it. It's also just looking at the plain numbers. As I said before, the false positives were highly mentioned by everyone. The true positives were not that highly mentioned by everyone, so they're all focusing on the false positives. And when you show them the numbers from all the findings, which were true positive, false positives, we had in, I believe, 6 months, no false negatives. That was amazing. When you show the numbers of the sensitivity, specificity, the predictive values, then they are really astonished, and then it was very easy to convince them to continue with the ADOC after the pilot, and still remind them of the primary goal of using AI. That's when you don't do that, it's going to change by I don't know what influences, but it's changing, and you have to remind them constantly.
It was technically and from the point of the user, meaning the radiologist, is quite straightforward. You start it up and it works. So IT-wise, I don't know if that was quite a big problem, but because this is the solution is working in a virtual machine, so the IT department just has to set it up with iDoc, and I think that was quite straightforward. The biggest problems, the biggest hurdles were in getting the IT department and the DPO of our hospital online and on the same page in this, why we needed that, and that all the GDPR stuff was taken care of. But once we had everything in place, the transition from not to using the solution was quite smooth. So the impact for us was, or the process of implementation was quite straightforward, and the way that it was actually taken over by the radiologists was also quite natural.
Before it was really my department, which is still yearly growing in numbers, and the rest is maybe slightly decreasing. So we're doing more imaging per patient, and I think that's where AI has a potential to have a first look at the scans or the images and point out the patients which need a radiologist to have a look at the scans. And next to that, I think there is a goal for AI to have a look at the non-used data nowadays. We for example, have just bought a new CT scan from Philips, an Icon, where you can almost unlimitedly play with the energy levels, and can make several number of images from the same patient, from the same scan, all which show different types of tissue, and maybe you can on one image you can see a beginning form of cancer, and on the other image is not. So it's impossible to look at all those scans for just one single radiologist in the time he has for it. So maybe AI has a purpose.
We don't have such an exoskeleton, if I may say, or an augmentation by software. You have to rely on your own knowledge, and your knowledge is built by looking at cases, by having supervisors tell you, you missed something here, and you have to read up, and so on and so on. So this process is, of course, definitely altered, because now you have a supervisor which is very quick. It's just 2 minutes away, day and night, so we don't know what kind of impact this has on their education, but so the jury is out there for such a question. I'm a little bit concerned about that, but on the other hand, we all drive fancy cars, and we have phones and so on, and everybody has learned to use them, and they're very reliable. They're always there. I think this is the way these things are going to evolve in radiology as well. We're going to rely on these kinds of software. And to go back to the old dinosaur days, if I may call them that, it's not really that, but the days where we didn't have this kind of software, in 5 or 10 years' time, in the big hospitals in my country, it's going to be unthinkable.